I'm Joe, I work for the NHS. I've been with the NHS about 5 years. I've done a few different roles there. My background is software development rather than user experience design. But I was working with a team earlier this year who were in the very early stages of looking at how we can transform NHS digital services, specifically the NHS Choices service. So that's what I'm going to talk about today, transforming NHS Choices with Agile and Lean UX. The subtitle of the presentation there, hopefully you can read it, is How to Get to Know Your Users so you can build the right thing. So we've done this presentation before at some Agile and Lean events, and I think Agile gives us this great toolkit, this great set of methods around delivering iteratively and getting fast feedback and so on. But it doesn't necessarily help you figure out what to build in the first place. And that's what this talk is all about, is those early stages of product development, figuring out what it is you should build for your users. And the main message for us in doing that was go and get to know your users. So I'm sure this will ring true for you as a UX audience. But I'm not just talking about running a survey of your existing users. I'm talking about finding out who your existing and potential users are, going and visiting them in their homes, talking to them about their lives, their families, the challenges they face every day, really trying to understand our users' needs. And this is what we did as we started to transform our service. We tried to put users very much at the heart of the transformation process. So I'm going to talk about some techniques that we used and give some examples of how we got to know our users and what we built for them. I think a lot of it will be familiar to some of you. Some of it was quite new for us, though. So let me just go back a step to begin with and give you a little context around the problem that we're trying to solve. So what is NHS Choices? The short answer is it's www.nhs.uk. The slightly longer answer is it's the main public-facing NHS website. And you can go on there and you can find information about medical conditions, and you can check symptoms, and you can find NHS services, and a whole lot more. There's a huge amount of information on there. And it helps people. We get good customer satisfaction ratings, and people could go elsewhere to get a lot of this information, but they come to NHS Choices largely because of the NHS brand. And I think it's quite similar to what you were saying about the Ordnance Survey. People love the brand, people trust the brand. There's a lot of power in that NHS logo of building trust with people. So if it does all this, why do we need to change it? There's a few reasons, but one of the main reasons is that our research shows that we're not meeting or we're not reaching as broad a demographic as we perhaps could. So the NHS is for everyone, right? It's for everyone in the country. But our research showed that the demographic, or the main demographic that we're reaching with our site was quite narrow and wasn't as broad as it should be. So we decided we want to transform the service. We had to start somewhere. It's a really big job, but we had to decide where to begin. So we looked at our analytics. We have a lot of metrics around the service. And we picked out some of our top journeys. I was going to say some of our most popular journeys, but popular is perhaps not the right word to use when you're talking about things like athlete's foot and thrush. So we picked out some of our most visited journeys, and one of the ones we picked, and the one that most of the examples in this deck are based on, is chickenpox, or of course, as it's more commonly known, the varicella zoster virus. So clearly, chickenpox is not more commonly known as varicella zoster, but we put this in because we had, well, if you went to the Choices site maybe 6 months ago and you searched for chickenpox, you would see this bit of text, that the Latin medical name for chickenpox, quite prominently at the top of a page. And we had this idea, or this hunch, that if you're a parent and you've got your baby in one arm and it's got a rash and it's crying and it's not very well, and you've got your phone in the other hand and you're trying to look up information about what could be wrong with your child, we figured that Latin medical names would not be the first thing that you wanted to see. So we wanted to test this idea of moving from being a kind of health encyclopedia to being more of a practical guide for users. So we picked chickenpox. As I say, it ranked highly in our analytics. It's symptomatic. We wanted to explore something symptomatic. And we wanted to explore the emotional state that might be attached around this. So again, going back to the example of a parent caring for a sick child and going online to look for information about that, we figured that might not be the same emotional state you're in when you're, say, booking a holiday online or renewing your car tax online. And we really wanted to explore that emotional state. So, having picked some topics, one of which was chickenpox, the first thing we did was go and call out some assumptions. So we make assumptions all the time, right? And often they're quite implicit and they're quite hidden away. And they're hidden until they come back and bite us later on. So one of the aims of this first exercise was to get all our assumptions out in the open. So we got our whole team together, and that was quite a common theme through this work, getting the whole team involved in all the activities that we did. We respected individual specialisms, but we tried to get the whole team involved in everything we did. We got the team together and we started writing down assumptions on stickies around chickenpox, either around our users or around our service. And we stuck those on a wall and we plotted them on these two axes. So the vertical axis there is an axis of uncertainty. So the assumptions we know the least about are higher up, the things down the bottom are things that we know a bit more about. The horizontal axis is an axis of importance or urgency. How important did we feel it was to know more about that assumption right now? So the things over on the right, we felt we need to go and figure this out. Things over on the left, maybe not so important right now. So maybe unsurprisingly, most of the assumptions initially were in the top right quadrant. That's the stuff we don't know that much about, but we felt we needed to go and figure out. So we've got this kind of prioritized list to work through, starting at the top right and moving down towards the bottom left, things we can go and learn about. And this was a really good exercise just to get started with. It was really open-minded. Nobody tried to kind of prove or disprove each other's assumptions as we went through this exercise. It was very much an idea of sticking them all up on the wall and then let the subsequent learning go and validate or invalidate the assumptions. So hopefully you can see how we got started. We got going by creating this list of things to work through. One of the next things we did, in parallel with a couple of other activities, was to start gathering evidence. And we looked at a whole bunch of sources. So we looked at analytics. As I say, we have a lot of analytics around the site. We looked at on-site analytics like Google Analytics and Web Trends. We looked at off-site analytics like Hitwise. Hitwise will let you do things like see what your users are searching for in Google after they've left your site, which is pretty powerful for finding gaps in your service. We looked at our existing service desk tickets to see if there are any common complaints or gaps in the service that people were talking about. We looked at social media. We looked at existing research because we didn't want to reinvent the wheel. And we looked at our search metrics and we looked at user surveys. We ran some custom surveys on the site around symptomatic conditions. All of that started to get us some insight. We were starting to gather insights around our assumptions. And in parallel with that, we did a couple of other things. We created some really simple task-based personas. So initially, we weren't interested in really detailed personas. We did create those later after the research, but initially we were just interested in the task people were trying to perform. We didn't care about people's politics or the car they drive or anything like that. It was very much about the task. So our initial persona was as simple as a parent caring for a sick child. And it was good to do this early on, mainly so that we could then go and recruit people. We knew who we were going to go and talk to. Once we had those personas, we started mapping out some user journeys. I'm sure this is all really familiar to you. Again, getting the whole team together, getting the whole team involved, trying to start thinking about how these parents might think and feel and behave when they think or they know that their child has chickenpox. So we looked at what they might do offline, what they might do online, if they would come online at all. We weren't trying to center these journeys around our service. If there were journeys where we felt people would go online and would experience our service, then great, but we weren't trying to center them around our service. And I think the other point on these is that they're hypothetical. We map out some journeys, but we could be completely wrong. We're just guessing at this stage. But all of this work, the user journeys, the simple personas, the gathering of evidence around assumptions, it all helped us to frame the next stage of this work, which was all about going and getting out the building. So we felt at this point, we'd done quite a bit of desk research, and it was time for us to talk to some users. So we could have done some simple pop-up testing. We could have gone to a cafe or a station and started talking to people. But we wanted to speak to people who'd had quite a specific experience. We wanted to speak to parents of children who'd had chickenpox to understand their needs. So we started recruiting those users, and we started interviewing those users. And then for me, this is where the fun really started, just seeing for myself and the whole team seeing for themselves how users thought and what they said and what situations they found themselves in. Absolutely fascinating. So we're trying to speak to parents of children who had chickenpox in the last 3 months. It was really important to us to get recent experience. We didn't really want to talk to people who were saying, oh yeah, my kid had chickenpox like 8 years ago and I think I did this and I might have done that. It had to be recent. And interestingly, 2 of our team have kids that caught chickenpox during this work, which we thought showed quite good commitment to the team. But so we did some of our interviews initially in people's homes. We went and visited them. We felt that would give us a good feel for how people behaved in their own environment. We did a lot of interviews in specialist research facilities, like what you see here is the team sat behind a two-way mirror watching an interview take place. I guess what you can't see is there's probably about 10 people crammed in there. And this was really good. Again, it's a kind of running theme here, but getting the whole team involved and getting the whole team in front of users, seeing for themselves what users had to say. That was a really powerful motivator for the team to see that context for themselves. And although we were very specific in wanting that recent experience, we wanted to speak to people from a really broad range of backgrounds. So we recruited people from a really wide range of demographics, different genders, different ethnic groups, different levels of internet confidence, different levels of digital literacy. Because, again, with the NHS, we're for everyone. It's not okay for us to go and speak to a bunch of white middle-class 20-somethings who all have an iPhone 6. We've got to speak to a broad range of people. And I think this, I know a lot of you will do interviews like this already. I think it comes across as quite a simple technique, but I think there's a really understated skill in being able to talk to a member of the public for an hour or so, keep the conversation flowing, elicit all the information that you want from that person, but whilst not biasing them in any way at the same time. And we're really lucky. We have some really skilled user researchers who are great at that, and I absolutely love watching it. I think it's brilliant. So as we were running these interviews, we were taking notes, and we had the whole team writing down on stickies insights and observations and capturing direct quotes from users. And at the end of a day of interviews, we would end up with something like this. A lot of data was captured, and we had to make sense of that. So we went through a process of affinity sorting. The idea with this was to get all of these observations and insights and observations and insights and quotes grouped into some themes. There's a picture on the left there of the team going through the process, and what we aim to end up with is something like what you see on the right, which is a nice, neat, ordered set of themes with insights and quotes and so on underneath them. And it was an iterative process. It worked best for us when we had the whole team behind the glass all day, because we could start to come up with a list of themes as we were going through the day. Then we'd start the process, we'd be grouping insights into themes. We might find a theme needed to be split out into 2 separate things. We might find actually all these things are the same, let's group them into one theme. So it was an iterative process, but we'd end up with this nice, neat set of themes at the end of the day. And then we could start coming up with some actions. What were we going to do next? We were doing week-long rounds of user research, so what were we going to test with users the following week? What were we going to talk to them about? And because we were doing week-long rounds of research, we always had to prioritize. We never had the capacity to test out all the ideas that we had. And again, we did this with the whole team. And it made for some long days, but we tried to do it back to back. So we would have a day of interviews, we would do a bit of sorting, we'd come up with some themes and some actions, and then the whole team would prioritize them together, and we'd go out of the end of that day knowing what we were going to do over the next 3 or 4 days and what we were going to test the following week. So once we had our actions, we wanted to make them a little bit more robust and a bit more scientific. So we started expressing them as hypotheses. So this is one example of a hypothesis we tested. And it came out of it was a really common theme in the first round of research that we did. Almost every parent said to us that when they thought their child had chickenpox, they wanted to see images of the rash so they could compare it to what was on their child's skin and try and validate for themselves whether their child had chickenpox. And that sounds quite obvious, but I'll show you in a moment what our current site offers in terms of visual identification. So we said we believe that providing an improved method of visual identification of chickenpox for parents will achieve an easier way for parents to successfully validate their child has chickenpox. When testing this by showing a variety of visual and textual methods of identification to parents of children who've had chickenpox, we learned something. So that's a bit of a mouthful there. I think we could probably trim that down. But I think it was quite similar to one of the templates we saw before in the analytics presentation around if you can't fill it in, then there's probably something wrong. You need to be able to express your kind of your idea as a hypothesis. I mean, this was a nice framework for us to kind of plug our learning into. So this is what the current site offered in terms of visual identification. There's a couple of images there, nasty images of the rash. Yeah, wait till you see the prototypes. But they're just kind of dropped into the text. They're not really linked to the copy that's with them in any way. That just feels like a couple of images dropped in. So we felt we could do better. We felt we could build some prototypes and test those with users. We only had 3 or 4 days to turn those round. So we could have built some quick and dirty code and deployed it to the cloud and tested that, but we didn't really go anywhere near that. We built 4 prototypes in an afternoon, and they looked something like this. So these were built in PowerPoint, and then we printed them out on paper and tested them with users on paper. I think it's important to say we're not trying to design the interface at this point. We're not trying to, for example, in the top right prototype, we're not trying to suggest that we would build an interface with sliders that users would interact with. We're just trying to test a concept of users being able to change the type of image that they're looking at. And I think the other good thing about doing these in such a low fidelity way was that nobody got too attached to any of their ideas. No one in the team was going into the next round thinking, oh, I want to make sure my idea is right or my idea is the best idea. If all of these had been thrown away after the next round of research, I don't think anyone would have been upset at all. So we got some really good learnings from these. People hated the image of the back. One guy said that we would have to show a warning on the internet if we were going to show that image. But on a practical level, they felt it was zoomed too far out. It wasn't helpful in terms of being able to identify the rash. But equally, in prototype D, they felt that that was zoomed too far in. Those images could just be a spot or a zit. They weren't chickenpoxy enough. What users did respond well to and felt was useful was multiple images showing the different stages of the rash with accompanying text saying what essentially text describing what the image is showing to them. And you may not be able to read it, but in the bottom of prototype B, that bar there is an idea of a kind of skin color or skin tone selector. And again, that came from talking to a really broad range of people. And we had black parents saying to us they found it really difficult to find good images of the chickenpox rash on black skin. So we had this idea of being able to change the skin tone that you were looking at. So we took those learnings and we plugged them back into our hypothesis template. And this is just one example of a hypothesis we tested. We tested a whole range of hypotheses, and with some of them, straight away we'd want to go and iterate the prototypes again and test some ideas further. With other hypotheses, we'd feel that, okay, we've learned enough there, let's park that on our backlog for now and go and focus on some different areas. But hopefully you can see the cycle that we've got into of talking to users, gathering a load of insights and grouping them into themes, coming up with actions from those, building prototypes to test those actions, and going around that cycle again. So to bring all that together, we began with assumptions, we gathered evidence around those, and we created some really simple personas and user journeys. We then went into 4 week-long rounds of user research. And as we went through those rounds of user research, the fidelity of our prototypes was increasing. So it's interesting that in the first round, there was a bunch of people in the team, myself included, who were really keen to just go and build prototypes and put them in front of users straight away. And our researchers, I think, rightly pushed back on us and said, don't show users prototypes in the first round. You will bias them. Just let them tell us their story. Ask them questions. I think we showed them some of the existing site, but we didn't show them prototypes in the first round, and I think that was the right thing to do. So in the second round, we were showing concepts like the visual identification prototypes I just showed. By the third round, we were starting to explore things that looked like navigation, and it was starting to look a little bit more like a website. And by the fourth round, we were iterating those further. So as we're going through this whole exercise, we're increasing our learning about what users wanted. We're increasing our confidence in what it is we should actually be building for our users. So to show where, I don't know how well you can see it, but to show where we kind of got to after our fourth round of research, this is one of the pages that we built. And if you compare this to the current site, you would see here less content. So we really tried to focus in on the content that was actually important to users, the stuff they needed. Again, that idea of moving away from being an encyclopedia to being more of a practical guide. And at first, this was quite uncomfortable for some people because it felt as though we were sacrificing content and we were taking away all the stuff that we thought was useful. But actually, I think we were distilling down to the stuff that people really needed. We made a lot more use of bullets and headings and chunked up the content to make it easier for people to digest and read and find the bit they were looking for more easily. There was clearer calls to action there about what people should and shouldn't do. The green bar is telling people that you don't necessarily need to go and see a doctor if you think your child has chickenpox. So again, this guidance element. And of course, imagery is kind of promoted to being a very much a central part of that page. That page is all about if you think you have chickenpox or you think your child has chickenpox. That's what that page is aimed at. And we implemented above the images there, I don't know if you can see it, but there's a little drop down and we tried to implement that skin tone selector feature. So that's where we got to after our fourth round, and we would then have to go and we tested this further. We tried to apply some of the design patterns to a bunch of other conditions. We knew that the needs we got for chickenpox weren't going to apply to, say, a cancer or arthritis or diabetes, but we did feel that there are a bunch of kind of common conditions that people will have heard of that they think they might have that the same patterns would apply to. So we started applying those. So I called this side effects, but I think actually, with hindsight, one of the main lasting effects of doing this work was the cultural change that it started to affect in our team and throughout the wider organisation. And there's a nice quote here from the chap who heads up Google's equivalent of HR. And he says, even a small connection to the people who benefit from your work not only improves productivity, it makes people happier. And I think we saw this. We got the whole team in front of users. All the team were involved in user research. I think they all saw the value in getting directly in front of users and seeing for themselves what users had to say. We had people saying it was the best work they'd done in 5 years. And I think it was a really good reminder of why we all do the job we do in the first place, why we get up in the morning. So there's the main message again, get to know your users. I would be really interested in hearing about how you all do this. As I said, I'm not a UX specialist, but I find this absolutely fascinating. We're the NHS, so we're trying to do things in the open, so it'd be great to discuss this further. And very last of all, I'm up here taking credit for my team's work, so I'd like to credit them. Thanks very much for listening.
Great talk, on time. I think we'll have a question or two before lunch. It's always nice to see kind of user experience thinking applied to projects that actually impact so many people. So, for me, that's supremely encouraging. And also, I think the way that you did it, I think I just want to say this point about fidelity. I've seen a number of people talk about it. Fidelity in the design process needs to be considered in the right way. I just kind of tweeted an article I wrote about it about 3.5 years ago. Fidelity is important, and I think that the way you spoke about it is good. Sometimes people can dive too deeply, too quickly. It's also a point, Craig mentioned it. It's like, as designers, we need to understand fidelity. It's pretty critical.
We were just trying to learn as quickly and cheaply as possible what we should build.
Do you know what? You've that took me years to work out, so great. Enough of my questions. Who would like to ask Joe a question? Ben. I'm going to go for Ben. Favoritism. Okay. Where's the microphone?
Hi, sorry, slightly geeky question that you partially answered at the end there, but when you're talking about this process, you're obviously going through this design process for chickenpox.
Yeah.
And I was going to say that how did you then sort of abstract out the information for general information around diseases, and how did you categorise that?
Yeah, it was one of our big challenges, kind of from outside the team. We got this, yeah, you're doing chickenpox, but that's great. There's like 1,000 conditions on NHS Choices. When are you going to do the rest? So we did a couple of things. Again, we looked at analytics, and it's like a long tail of traffic on conditions. So we knew that if we did the top 100 conditions, that covered 50% of our conditions traffic. So that kind of starts to make the problem feel a bit more tackleable. And yeah, we essentially tried to extract sort of patterns. So we were trying to look at the different pages that users, so that you probably couldn't read it on the navigation, but it's something like, is it chickenpox was one page, one set of information. How do I treat it? And then the third was just what else do I need to know? And those were the sort of buckets that information fell into. It was interesting because we then felt we could apply it to a bunch of other conditions, and we did. So things like cold sores and athlete's foot, common things that people have heard of, that they might actually Google that as opposed to Googling a symptom. It kind of worked for those. But then straight away, things like thrush broke the model because that's a kind of recurring condition, or can be a recurring condition. So prevention suddenly came into the frame, which isn't an issue with chickenpox. So it's almost a bit like building up a sort of library of possible content elements for different conditions and then picking out the ones that would work for different conditions. And we're looking at the moment at diabetes, which of course is a whole different thing again. You wouldn't self-validate yourself with diabetes, but you probably, well, we found you do need a lot of support straight after you've been diagnosed. So I think you could probably group the kind of 1,000 or so conditions on the site into, off the top of my head, maybe sort of like 10 categories, and get common design patterns for each of those.
Great. This lady with the golden top. Is it golden? Okay. That was a compliment.
Thank you. So sometimes you have shit days at work, and everyone has shit days at work. And I work somewhere where we sell clothes, and that doesn't really matter. And people buy clothes or don't buy clothes, and people could be running around like headless chickens at the end of a work day and be like, today was shit, everything went wrong. And I say, don't worry, because we're not saving lives. How do you deal with the fact that your job kind of does?
Yeah, okay, that's a really good question. So that's an interesting question. And I think, okay, so I'll answer that in two parts. I think there's a challenge that we have, that everything has to be clinically safe. So people were really, even though it was only chickenpox, people were nervous about putting new content out onto the internet to the public without some big label saying, this is an alpha, do not kind of take this as being, do not follow the advice here, sort of thing, even though we were pretty sure it was clinically safe. But yeah, in the back of your mind, there is a sort of risk that if you get it wrong, it could have consequences. So yeah, there's definitely a challenge there. I guess the flip side is that it's a really good motivator. So, it's kind of a tangent, but our organisation has been through N number of kind of restructures and been through a load of crap over the last few years, but people stay. And people stay because they give a shit and because it's the NHS. And as you say, it's important work. I don't know if I've answered your question there, but there's kind of a couple of points on that.
One more question. Actually, we'll have two more questions because I'm going to give Craig the option as well. I feel bad if I don't.
Hi, thank you. At an Eventapart conference last year, Eric Mayer's authority on CSS talked about designing for crisis, and he gave his very personal story about his child who went to hospital. Yesterday, somebody spoke about crisis as well, storm and flooding in a city in America. I kind of guess that people in the NHS or needing the NHS service will need to get in touch because of crisis moments. So did you look at crisis moments? And if you did, how did you go about doing that?
do you know, I think in this work we've not really looked yet at urgent care. We did, well, okay, so we did look, one of our other topics was dental or dentistry, and so we were looking at things like how do people want to choose a new dentist and quite mundane things like that. But then there was the, holy crap, I'm in a lot of pain, I need some help, and there was like exploring the need around that. And we generally found in that case, people weren't that interested in online. People wanted to pick up a phone and speak to someone so they could get some reassurance that they weren't kind of being silly, that they, their pain was important. So it wasn't straightforward what a digital solution to that would be, straight off. I know there is another team in the organisation I work for who have been working on a pandemic flu service, which should never go live, as in should never be kind of deployed, but has to be there in case there is a flu pandemic. So they've been looking at user needs around that. I'm not exactly sure how they've done that, because how do you find someone that's experienced a flu pandemic? You probably can't do that. But they probably had to, spoken to people and tried to have a good guess at what the needs there are.
Yeah, thanks. I think Eric said he was just looking for a telephone number, which I think is pretty much what you said, times of urgency.
Yeah.
Craig?
I think there's one problem I've always discovered with hypotheses, and that is they remain an informed guess until you've had some validation. So the question I'm going to ask is, what metrics, you know, did this content help you? Yes, no. How were you able to compare what the positive benefit of doing this work is to then motivate the team? Say, wow, like 20% more people do this or do that. How are you measuring success here?
Yeah, okay. So this work was really just about the early stages, so getting a kind of a feel from speaking to users face-to-face, so small numbers. And so having the team in front of that, you could generally get, I mean, people kind of challenge, but you've only spoken to 8 people, but you soon start to get a feel for whether something is being received well or is helping people or not. In terms of gathering metrics, this work I've shown you has not actually gone live on the internet, but we did some work around what KPIs we would have for this stuff, and it's not as straightforward as transaction completion rates, because people aren't completing a transaction. They might be dipping into one page. They might already know the child has chickenpox and come to the treatment page, might get what they want. So then bounce rates could be a good thing, or they could be a bad thing. It's hard to tell. So yeah, we were looking at things like just a simple, did you find what you were looking for? Yes, no. And if it's no, what were you looking for? And kind of maybe then some more in-depth exit surveys as well. But yeah, the kind of, the basic one is, yeah, did you find what you were looking for? Yes or no was what we were going to look at.
Yeah, I think that's great. You could also get them to self-select into the persona types so that you can compare those answers across those different groups.
I mean, we had ideas about doing more measurement around, if we could do it, it'd be great, but actually measuring kind of GP, how many people are going to a GP in a particular geographic area for chickenpox, and then if we could actually kind of deploy our new version of our service in a particular area or something and actually measure, that feels like a more direct impact sort of measurement, but that I think is quite tricky.
You may be able to track as well that you get less calls as a result of people seeing those pages than the old version, so you can actually prove that it deflects costly contact.
Yeah, yeah.
Great. Please put your hands together for Joe.
Thank you very much.